So good evening once again and welcome to this session. So today as we are celebrating Children's Day, we at Rahat thought it would be great to talk about children and their needs, especially those who need special attention from parents, from caregivers, sometimes even those who come into our communities. So that's how I have invited Dr. Swetha Naveen, and she has is a associate professor from it's CMC Vellore, child and adolescent psychiatry. That's her department, and she's uh, just very passionate about sharing with us what exactly are the different needs as children have, and how we as adults, as parents, maybe some of us are caregivers, maybe teachers are there on this call, I'm not sure, but how we can care for them. So at Rahat we look at the whole person care, and through this whole person care needs we understand that as much as a person needs help, the caregivers need a lot of help in supporting a person who has these challenges. So today I'll ask Dr. Swetha to take us through. Maybe you can share a little bit about yourself, Dr. Swetha, and then after that I'll ask you a few questions, and then at the end of it probably we'll have something you can share, like from your experiences, how it has been caring for such children. And then at the end we will have the audience and those the participants to just share or ask questions from you. Okay, so that's how, like, we'll just go over that kind of a flow. Is that okay? Okay, so maybe you can share about yourself and just how you're you know probably come about to doing child and adolescent psychiatry, because that's kind of a niche. I've, for the first time I've heard this, and I'm really curious to know how you've come to taking this as a field.
Thank you, Dr. Vinita, for this initiative. I really appreciate all those who have joined. The fact that you've joined shows that at some point of time, I think you are either involved or you're a part of a family of having a child who's a part of the neurodivergent spectrum. Uh, about myself, as Dr. Vinita said, I work as a faculty in child and adolescent psychiatry. So, child psychiatry is a higher specialty of the core specialty of psychiatry. So, during my medical college days, I always wanted to be a pediatrician. And post my MBBS, I worked in a mission hospital. This is on the Indo-Nepal border. And about 2 years, I spent there doing mostly pediatrics. And that is what I actually wanted to do because of one reason: I love children. And I'm always intrigued about child development and how children are so sensitive, and how, as each one of us, as parents, teachers, the society, everyone actually has an impact on a growing child, and how that affects the identity of the child, and how that helps a child to grow into a confident adult. And so this is something which I was always intrigued in. What are the protective factors? What are the risk factors? And how you can bring paradigm shifts in the development of a child. On that background is where I wanted to do pediatrics. Curiously, towards the last part of my 2 years of work in Raxol, so I had my stint in general medicine. So that is where I saw a lot of patients with suicide, and and it seems so that probably it's God's gift. I had that skill to connect with patients, and I was able to really establish that rapport with families and help a lot of patients in that sense. So CMC, when we give our PG entrance, we have to select two options. The first option, the subject of choice. So automatically, having worked in pediatrics, my first choice was pediatrics, and second choice is where I wanted to decide. And with the guidance of some of my, professors, I thought, okay, probably I'll put psych as my second option. But something within me kept just saying that, there was so much of a disturbance that it kept saying that I need to put psych as my first option. In those days, probably, not many people take psych, and that was like completely opposed by my family and everyone. It was like, you're a merit student, and why would you destroy your career by doing psychiatry? So, but I could not ignore the disturbance in me, and I decided to take up psychiatry. And this interest for children and psychiatry coming up, so the last part of my training, I was in child psychiatry, and it was post. So that is when my nephew, I was the one who identified that post my training in CAP as a part of the residency. That is when I first learned about neurodiversity and autism. He was a normally developing child. All that only one red flag sign that he had was he was not responding to name call. And my learning experience in CMC helped me to, identify. At 2 years, he was less than 2 years when I identified it. But it took about a year's time for my sister to accept the diagnosis and seek help. So that profoundly impacted me, to take up child psychiatry. So following my training in MD psychiatry, I joined the child psychiatry unit as a faculty, and I continue to work there. So I see patients, both children with emotional and behavioral needs with average intelligence, as well as children who are neurodivergent. So we have a specialized division for neurodevelopmental disorders. So that's how the story. It's much more longer, but I'm sorry. I try to concise it and say it. Yeah.
Yes, great. So that's wonderful to, know that something which was very personal has prompted you or, given you the push to take up this as your profession and as your calling. So can you just give us I know there are, different people from different backgrounds, and some share that they have their own, their needs in their families. So can you just give us a definition, of what do you mean by neurodiversity in your practice and in your this thing? How do you define it?
So I think
Very simple, huh? Because we are all some of us
yes,
in the group are not from the medical background. So yeah.
yes. So it's actually quite challenging for us, because we're used to present on scientific platforms. So, but I'll try my level best to keep it as simple as possible.
Yes.
So I think as parents, teachers, you're all familiar with, probably growing up in school years, you would have heard about mental retardation. Eventually, slowly, I think over the last decade, people did start talking about autism, right? So, but there was something much more happening in the West. So,
That's all.
I think there's a disturbance.
Yes, today an NGO for mental health.
Yeah. So the term autism was coined by Leo Kanner, right? So now the whole understanding, the concept was about, when we see mental retardation, formerly known as mental retardation, now you call it intellectual disability. Then you're talking about autism. So these were named as disorders, right? So initially, the concept of it, a medical diagnosis was what was given to these conditions, and it's a defect which needs to be cured or which needs to be treated. That was the model. It's a disease model. Now, when you go with a disease model, these children were facing a lot of discrimination in the society. So as a part of social justice movement, so this was in the early 1990s, this term was coined by Judy Singer, the term neurodiversity. So this comes not from a medical background, but from a social justice perspective. So you're saying that neuro and diversity. So you're saying the normal brain, what you call it, neurotypical. So there is a typical development which is happening. And you're saying that this is not defective, but it's a variation, that these children are differently wired, and it's all a part of the heterogeneous spectrum. So we should not medicalize everything, but these children have to be given equal opportunities. And it's not that how do we change them to adapt to the society, but how can the society change, right? to support them. But it's not something anti-medical or anti-diagnosis. So you go with a strength and challenge-based approach where you support the child.
Yes, great. I think there's some echo. Yeah. Go ahead, Dr. Swetha.
Now, so that's been a huge push, right? So for the advocacy of for children who are on the neurodiverse spectrum, it's called neurodiversity. That when you say the term neurodiversity, I can request Dr. Vinita to share the PPT so that I just want you to be familiar with few terminologies. Can we go up to the
You can see this? Yeah, okay.
you can see the screen. Further up. Yeah. So
is this the one?
Yeah, this is the one. So these are some of the terms which I want you to understand. Neurodiversity is the natural diversity of all human brains. And we are seeing that these neuro minorities, the majority of people may be processing sensory information, language, communicating in a particular way. And these children are just a variation and it's not abnormal. That's what neurodiverse is talking about, the group of people who have these variations in their brain type. Neurodivergent is an individual. Now, when you talk about spectrum, you're talking about traits which are a part of the neurodiverse spectrum, that people can have certain elements. Like, for example, somebody can have an anxious trait. Somebody can have a perfectionistic trait. So in the same way, somebody can have an autism spectrum trait. So from trait to a fully blown disorder, a clinical disorder. So it's a wide spectrum. Can we go to the next slide, please? So neurodiversity is about celebrating variations, right? We are saying they are different and they're not less. So it's just that there are diverse ways of thinking, learning, and behaving, right? So in fact, my nephew, when he was 2 years old itself, he was able to read like big sentences, big words. He was very good at spellings. So this is moving away from a medical model to an inclusion and strengths-based approach. So the whole idea is to equip the families to nurture the strengths of the child and not just fixing the weaknesses. Next slide, please. Yeah. Now, this is an important question, right? What caused this? Now, I want you to understand this normal distribution curve. So if you see this normal distribution curve, right? So 95% of the individuals, right? So majority of individuals are in this bell-shaped curve distribution.
Okay.
So this is how a normal brain would look like. Now, if you see, I'm not sure if you're able to appreciate the light pink color. So this light pink color in this, as towards the end of the bell curve, you're seeing this pink color increasing. So somebody can just have just and then move on, and then somebody can just be at the end of the tail of the curve. Some people can be completely out of the curve, where this pink, this neurodiverse brain, it is affecting the entire brain development, right? So the whole focus is like to understand that all these are a part of the normal variations. So we may be seeing people at the tail end, but we should not go with medicalizing everything and name it as a disorder. Understanding that it's a lifelong process. Development is a process, a journey through which a child goes, and understanding that this child is differently wired. Now, what is causing this? Now, so we are more and more seeing increasing prevalence of these conditions. So it is not a particular cause. It's not just a vaccine which has caused it. It is not just parents feel guilty that we've given our child a lot of screen time. Is that the reason why this has happened? Not really. So there is a complex gene environment interaction which is happening, leading to epigenetic variations, leading to the risk of increasing of putting these children at the risk of developing neurodevelopmental conditions. Now we all know that the world is rapidly changing. The culture, the environment, the toxins that the children are exposed to, the natural foods. There's so much of change in the environment. All these factors put together puts children at risk of developing these conditions. Yeah, so that's in just about what is neurodiversity. Now there's a huge list of conditions that are covered under this umbrella, starting from autism, ADHD, intellectual disability, specific learning disability, Tourette's syndrome, right? So OCD. So a lot of conditions. One is from a developmental perspective, you have one group, and the second group is, probably following epilepsy, they can have a regression. So it's a diverse umbrella, but I think today we will stick to, 4 disorders, that is autism and intellectual disability,
Yes.
ADHD and learning disability.
Yes.
Over to you, Dr.
Yeah. So can you just tell us, like, what are some early signs that families or teachers should look out so that they can identify these, especially since now today we are focusing on more on the neurodevelopmental conditions. So what is some things that the families or teachers or any caregiver would be able to, like you said, your own example, how you were able to identify that with your nephew?
Yes.
So can
So
you
we'll
share?
go disorder wise. First, we'll focus on autism, right? So we've had children, as early as even 11 months who were brought to us with the signs of, people who have recognized this. So the awareness is very important. So first is we need to be aware of what is normal, right? What is normal development in terms of what a child is expected to achieve at a particular age. Now, when the child is not achieving that particular milestone, if there is a developmental delay, right? So if you typically see at 2 years of age, a child starts cooing. At 6 months, 6 to 8 months, you can see child starts babbling, right? So when you laugh, you make a baby smile, right? So the baby is responding, right? So when you see the baby is not reciprocating, so if there are no words by the first year of life, the baby doesn't seem to reciprocate, right? These are all early red flag signs that the baby is not engaging. And as the child grows, you see that the social milestones like, 12 months children say bye, wave bye-bye, and pointing. Children, this is called instrumental pointing. When children want something, they need to point their index finger and ask for that. So absence of instrumental pointing, not responding to name call, not following the normal social gestures. These are some of the signs. That is, so the 3 core deficits in autism is, one is the deficit in reciprocal, in the social interactions. That is one. So you look at the non-verbal, right? The eye contact, right? How is the child, whether the child is recognizing the mother, right? How is the language development of the child? So that is one domain. Second is, you see a lot of repetitive behaviors in these children. Like these repetitive behaviors can be motor, where these children are spinning, right? They can have hand flapping. They can have, like, they will be flickering their fingers, right? Or, they can have some vocal sounds, or they can endlessly stare at a particular object, or they can look at spinning objects. So they can have repetitive behaviors, and they can also have sensory issues. So they can be like very sensitive to sounds, or they can be seeking also. So like, for example, they might be seeking certain sensations, like they may be repeatedly jumping. So you see these deficits in these areas, then you should suspect the possibility of an underlying autism spectrum disorder. The second is ADHD, right? So when you talk about ADHD, now also need to understand that, like we've seen the bell-shaped curve, that some of the children can have these traits. Now, the presence of a trait doesn't make it a disorder. So when should you be alarmed is when there is an impairment, when the overall development of the child seems to be stalled. That is when you need to be concerned. It's always better to err on the side of doing more, because the first 5 years of a child life are the golden years, because of the brain is growing rapidly. So every early intervention has a better prognosis. So as a parent, if you have a doubt, if you're seeing these red flag signs, no babbling, no words, no meaningful words by first year of life, right? Child not making eye contact, child is not waving by, and you're seeing some repetitive behaviors. Child is not playing with other children. Child prefers to be alone. Child seems to be very sensitive to certain sensory input or seem to be seeking. So it's always good to go and see. So in the same way, ADHD, so some of the symptoms can be seen in age. Like for example, if you see a 3-year-old child, hyperactivity is normal in a 3-year-old child, in a toddler. So that doesn't make it ADHD, right? So when do you call it ADHD? You're looking at either hyperactivity, where a child is not able to sit in one place, a child is always on the go. Child can be accident prone, keeps falling down, right? So child is not able to pay attention, right? Child keeps forgetting, child is very impulsive, not able to wait for turns, right? So, and they have a difficulty in executing a command. You give a command, they forget about it and they come back to ask you what it is. So if there is a hyperactivity and inattention, either of them or both of them, it has to be across settings. That means these symptoms have to be both in the home setting as well as in the school setting. And this symptom should cause an impairment with regards to probably learning. Because say, for example, a child is so hyperactive that the child is constantly squirming, constantly on the go in the classroom, disrupting the class, not able to pay attention to the class. So that is interfering with his learning, right? So that is, then you need to suspect the possibility of a ADHD. Then in intellectual disability, you see an overall delay in the development. So you see the comprehension seems to be slow, and even general skills which a child has to pick up. So the child seems to be slow. So that is when you have to suspect the possibility of an intellectual disability. Now, autism and intellectual disability most often coexist. So 70% of children with autism have intellectual disability. And then last, specific learning disorder. Children who have average intelligence. Like for example, if a child scores all subjects above the pass mark, child is able to pass and do well. But there are specific areas, like for example, an arithmetic difficulty. If the child is scoring only 30 out of 100, like 2 grades, like for example, child is in 7th grade, but child is able to function only at a 5th grade. So it is 2 standard deviations. The child is scoring lesser, but all other subjects, the child seems to be doing well. So this child who has an average, a fair intelligence with specific difficulty, it could be in reading, or it could be in spellings, where they make a lot of spelling errors. They may jumble up words, they may reverse alphabets. It can be writing difficulties. So is it a learning difficulty or a disability? When do you call it a specific learning disability? It is only when you do standardized assessments to say that this child has an average intelligence, but in specific areas, the child is 2 standard, like say 2 grades lower than what is expected for the child's age. That is when you suspect an underlying SLD.
Right. Yeah. Thanks. So that's what just wanted to know, how can families differentiate between a behavioral, sometimes he's just disobedient. He's not listening to me, so how do parents or caregivers differentiate between that? It's just behavioral or it is a neurodevelopmental condition? Can you help us with that also?
Yeah. So behavior problems are seen in children who are typically developing as well as children who are on the spectrum, right? So I don't think we can exclude in either of these two groups, both in the
Okay.
neurotypicals and the neurodivergent. Now,
Right.
how do we differentiate is now children with behavior problems, we need to understand something called ABC. What is the antecedent? What is the behavior and what is the consequence? Now, if you see behavior problems in typically developing children, it could be one is probably it can be so that there is some amount of, for example, a child who is bullied in school, right? So child may be intelligent, just that the child's temperament, like by nature, the child may be very withdrawn, a slow to warm up temperament. Now this child bullied in school comes back home and has behavior problems, right? So when we say behavior problems, it is externalizing behaviors. Like the child can throw temper tantrums, the child can be adamant, probably throwing things. There are different types you can define behaviors, but there is a clear antecedent, right? So now there will always be an antecedent for every behavior problems, but in typically developing children, you can clearly see there is a stress. So there is some problem either in the school setting or in the home setting. Like for example, if the child is in an adverse family environment, like for example, there is a marital discord between two parents, and so the parents are not giving attention to the child. So when the child, especially throws a tantrum or something, that's the only time parents attend to the needs of the child, right? So in typically developing children, there'll be clearly either a family dysfunction or there is some problem in school. There are clear antecedents, right? And with behavior modifications, these children, and sometimes it can be possible that some children who come to us, they say that, oh, the behavior is only in the home setting. The teacher doesn't seem to have a problem that this child is having these obedience issues in the school setting. So when the problems are only in a single setting, a clear, antecedents, there is a family, problem in parenting, parents who are too lenient or parents who are too strict, both.
Okay.
And there is something that the child is going through. Even typically developing children can have behavior problems. And this can be perpetuated by parents giving reinforcement, like child crying for a phone, parent gives in, behavior will tend to recur.
Correct.
But in a neurodivergent child, along with these behavior problems, there can be sensory issues because of which the child, like for example, a child on the spectrum cannot communicate a need when the child is hungry. So probably around meal times, the child starts throwing a tantrum.
Correct.
It could be a physiological need or it could be a sensory issue. So there will be clear antecedents to that. And a comorbid, what you need to look at is the developmental delay. That is one way to kind of differentiate. Yeah.
Right. So, okay. So once the, family comes to understand this, what are some of the things that, they should be doing? Like, what kind of professional help should they, approach, like, so that they are screened properly, they're diagnosed, and they're treated properly. So can you just give us a little bit on that? How can families be helped?
So in my clinical experience, parents are actually experts at this. So, parents do, especially the maternal instincts, do perceive that there's something missing about my child. But most often the diagnosis gets delayed because probably it is a culture where probably
Yes.
the extended family say that, oh, it's a boy child, he'll grow out of it. Or, even your like this person in the family had this problem. Now see, this person is absolutely fine. So in that context, they tend to delay it and they really don't know whom to go to. So sometimes, parents end up going to probably a therapist. We need to understand that in the context of managing a child who's on the spectrum, we need a multidisciplinary team, and that begins with a diagnosis. So it is not a symptom checklist. Now, if you look at medical classificatory systems, there will be a checklist of symptoms 1, 2, 3. Okay, child is not having, not maintaining eye contact or sensory issue. There can be a huge list of symptoms, right? So it is not just ticking off those symptoms and say the child has ASD. We need to look at the clinical context. We
Correct.
need to look at, does the child have any other medical comorbidity? Does the child have any other genetic problem, right? So a medical evaluation is very, very important. While occupational therapists, psychologists, all are involved in the care of these children. So I would recommend first a medical evaluation. Whom can you go to? You can either go to a child psychiatrist or a developmental pediatrician. The first immediate thing is you need to go to your own pediatrician, your family, your child's pediatrician. So sometimes I've also seen this, that pediatricians themselves, not now, but earlier days, the parents who used to come to us, they used to say, no, the child will pick up, right? Because the awareness of the early signs is limited. So if you're having that instinct that there's something, don't leave it, pursue it. So you see either a developmental pediatrician or a child psychiatrist, then they will refer you to a psychologist, a rehabilitation psychologist or a clinical psychologist who will do an assessment. So there are standardized assessments to say whether the child has a trait, or is the child on the spectrum, or is it at a disorder level where the child needs
interventions. Yeah.
And then as a part of the NDT team, you have so many people involved, the occupational therapist, the physiotherapist, the psychologist, and then you have, speech therapist. The entire MDT team comes into the picture.
Yeah, great. Thank you so much. So what are some of the myths and stigmas that you have encountered personally in your, practice?
Yeah. So I think one is with regards to autism, it's a boy child will grow out of it, right? So then, so that delays diagnosis. Then the second is, autism can be cured. So you see people coming up with, very, fantastic ideas that you do this, and parents are vulnerable. So they go from pillar to post, believing that these complementary therapies, people, in fact, in Mumbai, I've heard like stem cell, parents from different states. We are a tertiary care institution, so we get patients from different parts of the country. They come and ask us, okay, we heard in Mumbai they're doing a stem cell. We are willing to sell our whole property and go and do this if it is going to make my child better. And some of them have done that also, and they've come to us, spending lakhs of rupees.
I think your audio is low. 1 second. Can the rest of yours hear? Can you speak again, Dr. Swetha?
No, can't hear.
No, suddenly it has gone on mute.
Now?
Yeah, now it's better. Now it's okay. Yeah.
Okay. So, so these complementary therapies, going through, all these, a lot of alternatives. So, in a way that parents are going from pillar to post. So always remember, go to a qualified person, right? A medical person where you have a clear diagnosis, right? So after you get a diagnosis is where you move on to the treatment part of it.
Correct.
Am I audible?
Yes. You're audible.
Yeah. So this diagnostic process is important, and the treatment received. So the myths I was talking about. So it cannot be cured. So now there is trait. There is children who are the spectrum, and there is level 1, level 2, level 3, right? So
yes.
Children who are mild, most of these children with traits, they actually grow out of it, right?
Correct.
So even we can revise the diagnosis also. So, but that's one proportion where it's only a trait, right? Children learn to mask it and they grow out of it. Correct. But especially in the context of a intellectual disability, right? So it is about these children will do well. The mild, the level 1 group with minimal supports do well with the needed accommodations. But it's the severe who need support, and you will continue to need support. So this understanding in the search and pursuit of something which will fix the child, I think that's the main thing which is there, and they're constantly looking. So we have to tell them, even in a tertiary care institution, that even if you go to the United States of America, nobody actually has a solution which can completely revert your child's condition, right? Then ADHD and learning disorders, they think it's behavior, it's bad behavior, right? And today I had one child who had come to the OPD with possible specific learning disability. The mom kept saying how, he just he's not interested to read, right? He doesn't like to read. He's lazy. He's a procrastinator. So, so parents are not aware that there is a deficit, there is a challenge that the child is facing. So these children end up getting a lot of, labels.
Labels, yeah.
So these are some of the challenges that we see in clinical practice.
Correct. So can you tell me how can we as communities support such children in like I think sometimes even the families they can kind of get isolated is my understanding, because they have a child with this kind of a need. They're not normal, these kind of like you said, labels are put on them. And we know, like in an Indian environment, that people love to ask too many questions, especially the older generation. What's happening? Why aren't you doing something? So what kind of support do you feel that we can give, like, as communities?
So if you look at the evidence, the social participation of these families is very poor.
Yeah.
So one is the children. So again, I'm talking about, somehow parents feel that they're responsible for the child's condition. Like a child probably in a mall stimming, the way the community looks at the parent and the child, parents feel very uncomfortable even to bring the child out, because they might be looked upon with a judgment. Why are the parent not able to manage the child, right? So even probably these children getting invited for birthday parties, the social. So one is not being invited and not being included, and second, parents themselves making the choice of avoiding social gatherings because of these questions, because they don't feel welcome, they don't feel included. So I think there is a lot of need. Like, for example, there's quite a bit of an awareness among probably, one group of medical professionals and probably families who have children who are on the spectrum, or their extended families, specific groups who are interested. But there's a huge, larger community who actually is very indifferent, right? So that is why this term neurodiversity becomes very important, where, we need to fight for the rights of these children. So these children need, they have a right to dignity, and how, the community, when we say community, it involves schools, it involves social gatherings, and even religious institutions. All these places, we need to work on awareness, sensitizing the needs of a child with ASD. Like, for example, in my own family, my sister was saying she's homeschooling him. So in the homeschoolers community, initially she also used to perceive that he's being kind of ignored. But she took this session for the homeschooling moms about what is autism and how actually the child thinks differently, in what way to communicate with this child. So actually taking this session brought a paradigm shift in the way how children interacted with my nephew. There's a lot of education that needs to go in, a sensitization, and this, initiatives like this. So sensitizing the community and making community, like, for example, classrooms. How can schools be more friendly for children on the spectrum? How can we make sensory accommodation? How can we make educational accommodations? How in religious places, how can people step up and say, we're going to take care of your child, so that you can have some quiet time for yourself. So sensitizing the community by and large. So the whole movement of neurodiversity is, how can the community, the global community, come together to provide a safe place for people who are on the neurodiverse spectrum.
Lovely. Yeah. Yes, that's so important. I feel sensitizing people, so anything that you can tell us, the general public on, I mean, the parents may be already having so much of awareness because their own child is having this and they know how to talk. But how can we, on a whole, as a community, be sensitive in the way we talk about neurodiversity basically in an Indian context I'm looking at, because I think the other Western populations, they keep, they're very inclusive in everything they do. Like even for the handicapped, they have special, ramps created for them and those kind of things. But here in India, we have those challenges, So can you tell us how we can be sensitive to this population?
So so generally, like for example, if you have a children's event, now some of them may get invited, but they're completely ignored. They're completely on the background because the other children will completely steal the show, right? So having specific events for these children and families is important, right? Like for example, as a part of the World Autism Day, every year we have the social inclusion event where we sensitize our students. So where the medical students, the nursing students, the allied health students, all of them come, and each child, each a student volunteer is assigned for these children. And that day, so we have specific like event, like a carnival, a mini carnival arranged where, these students are taking care of these children while the parents are relieved of this responsibility of caregiving for that entire evening.
Okay.
So we teach the medical students how to, the students to interact with these children. So, because we need to focus on the next generation, right?
Okay.
So then, so this whole evening, it's very interesting to see how young people connect to these children, and it actually creates a profound impact. And alongside that, we invite our own staff kids, the campus kids, to come for this. So because primarily the event is for them, so these children learn how to play with them and giving these children the first priority. Like for example, say a bouncy castle for a child who has a sensory need, so the typically developing child learns to wait till the other child finishes. Normally, if you would see in a setting, so if the children are there, they might push down this child. But in this setting, in a controlled environment, you are teaching the child how to be respectful, how to be sensitive, right? So I think as parents, we have a responsibility. Like, for example, I sensitize my child. Like, for example, in my child's class, so there is a kid with ASD. So quite often I engage in this conversation of how she has to be sensitive. So, she's just in grade 1, and I was so surprised that, because of that sensitization, she comes and came and told me that, Mama, these children are bullying this child, and how she went and spoke that to the teachers. So I think as families, we all have a role to sensitize our children. Parents need to sensitize children, how they can create that environment. So as institution, as individuals, right from an early age, I think that sensitization for children, conducting events like this, like there are research to show that even like social events like sports events, so there are so many events that you can conduct for these families, and we need enough volunteers, to take care of those situations, take charge of it, and that is one way we can sensitize, right? Yeah.
Great. Thank you so much. I think this will be my last question, and then after that I'll open it to the participants. Are there any things that the government provides? Are there any benefits or supports to protect such children's their rights, or maybe the families are supported? Does the government do anything?
Yeah, there are certain rights, like as in government is also actually taking a lot of initiative, right? So one is, I think we need to be aware of the right of persons with disability. That's a 2016 Act. So this focuses on the child having a right for education, right? For, for jobs. So there is a reservation. So then having a unique ID, UDID card for all these children. So doing a developmental assessment, an IQ assessment for older children, and getting a disability ID is very important, right? So in addition to that, there are a lot of schemes also. Can you hear me? Hello?
Yes, we can hear. We can hear you. Yeah.
So there are certain education, like for example, even the curriculums, the CBSE board, the ICSE board, have on their board. If you go on the website, you will see what are the exemptions, but you need to have a certified specialist. Only a clinical psychologist with a registered RCI number will be able to provide a certification. So these can be submitted to the board and the exemptions will be given, right? And then also National Trust Scheme. So these are the schemes, there are certain schemes. So I think the first thing is to get a UDID number, right? And even the Mental Health Act. So a lot of changes slowly the government is bringing in. So now we, like with the Ministry of Family Welfare, and slowly at the district mental health program is focusing on developmental disabilities, trying to bring in across cities. Some initiative is happening from the government, but right, there's a wide gap. I think we have a long way to go, but these are some of the things which we can do.
Great. Thank you so much, Dr. Swetha. So now this is a time for the participants to just maybe unmute, or you can put your questions or queries on the chat box and we will ask Dr. Swetha to answer them. So anybody wants to unmute right away and put it, or somebody can put it on the chat box. This is really helpful. Somebody has asked, I think Ulka has asked, do access bar therapy or EFT types. I don't know whether it's a query, whether that can help. I'm not sure whether I didn't understand that.
So you need to understand what is the core intervention for children on the spectrum, right? So with regards to autism, I said the importance of a multidisciplinary team. So the core is the applied behavioral analysis, right? So all others are they complement. Like for example, people do art therapy, music therapy, pet therapy, some diet modifications. So omega-3 fatty acids. There is a huge list of all these complementary therapies, which do has anecdotal evidence, as in like there are specific case reports where some children have benefited from it. Now, when do you suggest strong evidence where a large number of children are treated with this and majority of the children have noticeable improvements, then you say the evidence is strong. For all the others, the evidence is is limited. It's very small. So we have to decide on a case-to-case basis. But definitely no for hyperbaric oxygen, stem cell, chelation therapy. These are all definite no.
Okay. Thank you. That's really good.
Somebody has asked, can you suggest some doctors in Bangalore? So St. John's Hospital, you can go to National Institute of Mental Health Sciences, NIMHANS, you can go. And you can also go to Bangalore Baptist. So these are few hospitals which are there, which you can go. You can either see a developmental pediatrician or a child psychiatrist as a first consultation.
Anyone wants to unmute and ask questions? So
Yeah, hi, my name is Niyati, and I just have a query that, as I'm a teacher in kindergarten basically, and I do have different types of kids and behavior issues. So there might be sometimes like the child was very good in within 3 months, and then all of a sudden showing behavior. So as you suggested that maybe in the house there was some problem, and then in the school they are showing, but is it like we can judge any idea for ADHD, like if the child is very hyper, sometimes very lazy, not responding, so any to how to find out that?
Yeah, so I think you should, so when you have a concern, it's good to keep a watch on the child. Like you need to closely monitor the child, like as in a structured environment. You're teaching, you give something, say you ask the child to engage in some drawing or something, because you mentioned it's a kindergarten class. So you have given some structured activity to the child and the child is not able to focus, where all other children are sitting, right? Then, as opposed to an unstructured where children have a play, a play environment where children are doing whatever they want, and this child is all over the place. So in a structured environment, if the child is able to sit, but in an unstructured environment is where the child is hyper, so it would be more behavioral. And talking to the parents, asking them how the child is doing at home. Also look at the child in the context of the peer group with the other children, how the child is behaving. So, and watch the child over a period of time. Take 1 week or 10 days to, persistently watch the child in terms of activity specific, how's the learning, the language development of the child. When compare with the and see, how much of it is a delay. So if there are clear antecedents, it's only for attention. Sometimes behavior problems can be like, if, for example, a child has a difficulty in maths. So are the problems happening only in that specific subject time? Or is it just pre-lunch? So we need to look at a lot of antecedents, what could be causing the behavior, and then make certain, like some things could be what is the classroom acceptable behaviors, what is not acceptable, and rewarding appropriate behaviors, and whether the child is conforming to those norms. So despite having certain, rewarding, and probably still the child is all over the place, you can give a timeout for the child where you say, okay, 10 minutes you can be in this corner to calm down yourself. It's not a punishment. A timeout is not a punishment. It is just to interrupt the behavior. So despite that, if you're facing challenges, then maybe worthwhile talking to the parents to just get an opinion.
Thank you, doctor, so much. And one more question, that as you said that music therapy is there are so many other therapies. But nowadays people say that maybe too much of music also creates stimulation in the child. So is it true, or like, because you said one of the sentence that it's not correct, because it is their brain wires are being like that. I was a bit little confused with that.
So children, definitely ASD children are differently wired. As I mentioned, music therapy, all these are just complementary therapies. But because there is already a sensory deficit there, a child can be hyposensitive, as in the child may be seeking or the child may be avoiding a particular sensory input. So it's the right amount of what you give, the sensory input is very important. Anything in excess can be problematic. And you should see case by case how each child is, is the music soothing the child or is it disturbing the child? So you have to see based on each individual child what is helpful.
Thank you
Hello,
so much.
Yeah. I think
Hello,
Princey
doctor.
wanted to ask. Yes, Princey. Yeah.
Yeah. So, hello, doctor. Thank you so much. I think what you're sharing with us this evening is like light, in the midst of the darkness. Maybe I need to talk more with you personally, maybe get your number and connect. But I think from what you shared, the issue I'm facing is my child is 12 and a half years old. And I've been working with her ever since she was 6 months. Um, we had a process of adoption. So I don't know what happened before the 6 months. But I don't remember any developmental delays after she was with us. And in every way, she looks normal and fine and intelligent. But I'm not able to get her to move academically. Like you said, she's always 2 grades behind, and I can't push her. Like nothing I do can push. The only thing that works is if she knows she's going to miss out something, or if she wants to get something, and if we say, if you do this, you can do that. But we don't want to parent that way. So that intrinsic interest to achieve goals, set goals at 12 and a half years is still not there. You can tell me if I'm telling you all the right information. But right from childhood, she kind of struggles with structure. Like if there's a class today at 6 o'clock, she would not remember it. If something needs to be done today, that will not get done. If we want her to get it done and say, only if you do this, then she would sit on it the whole day. But in so many other areas, like, reading the Bible, explaining, learning songs. There are so many ways I can see there's not a problem with intelligence. My question is, being a homeschooling mom, how can I differentiate between whether this is an area that is difficult for her and therefore I need to help her to drop these subjects or whatever and focus on other things, which I'm happy to do. If that's her strengths, we can do that. But I'm very confused between whether that is a difficulty or whether I have not been good enough or I have not done my job, trying to differentiate. And this is a very difficult battle for me. I want to believe that everything can be well, but I don't think I will be battling with something for 12 and a half years without there being any underlying thing. So it's difficult to describe the whole scenario, but I think, would you have anything to say in response to this?
So, like I was already telling you, one is we need to understand intellectual disability. Like an IQ score of less than 70 is when you have the cutoff for a disability, right? So, what is low average? What is borderline? Like, for example, a child having a specific difficulty, versus a disability. So we use the word disability when the child has an average intelligence and in specific areas, the child is performing 2 grades lower, right? So that is when you are talking about a disability. Now, overall, if the child is a slow learner, it's not just those 2 particular subjects, but overall there seems to be a struggle. So we need to really look at, so something what would help is we need to do a formal assessment to see, where exactly is it. So there's something called Bachelor Standard Intelligence Scale. So you do standardized assessments, you do a screening for specific learning disability. That is when you will have an idea of what are the strengths of this child, what are the difficulties of this child. So is there a problem amounting to getting an exemption? So I think that is what is needed. From what you have spoken, like, so there is a clear, demarcation in what she is interested, she is able to do, and what is difficult, she is avoiding, right?
Yeah.
So that kind of, so that's one struggle which parents do often face. So in that context, you need to understand that sometimes the abilities can be scattered, right? So in some things, children can be good at it, and in some things, children might find it difficult. So unless we do a formalized assessment, it's very difficult for us to pin down. Now it's like something very hazy. You're dealing with something.
Yeah.
That's not how a 12-year-old child should be. You feel that there is some gap. It's so if you remember, I drew the bell-shaped curve. So she might be the neuro minority where she's just at that end, where there are some deficits, there are some difficulties. So what you are saying is that initiative to do things, all that is not there. So it could explain an underlying executive functioning problem. So what part of the brain wiring is affected, and giving her that particular structure and input for that is something what I would recommend.
So, ma'am, how can I identify this? Because I've made attempts to go to the National Institute of Persons with Multiple Disabilities, NIPMED in Chennai. We went for a couple of sessions. After all the sessions, they just said, ma'am, we can't assess her because she's a homeschooler, and you're saying that she's 2 grades behind. So how can we assess her because she's not done division, she's not done LCM, she's not done this? My whole point is I'm trying for 3 years and she's not getting there. Like if I've had a problem, I've then engaged a teacher to see if the same problem is with them. And the thing is, I see the minute I engage someone else, they're more harsh on the child. They label so much. So I want to be the positive factor in her life, but because it becomes too much on me and nobody else is able to step into that part, I myself might be hurting her so much because there's no the end of the tunnel.
I understand that. So what you need to understand is, so we don't, label a child based on a cross-sectional assessment. So there is a challenge when your child is being homeschooled. So that is where, we kind of observe the child. We take time at least 5 days, usually when we ask a child for a certification. So we ask the child to come in for at least 5 days where we observe the child across settings. So through the day, there are multiple people who are observing the child, and then there is an assessment going on. These two things together is complementary, is where you give a comprehensive report. So we have to see if it is not based on the academic thing. So we'll have to look at alternative tests. So definitely the clinical psychologist will have alternative ways to look at it. So
Yeah.
I
I
would
think
suggest,
we should, yeah, I think Princy, we will get you to contact Dr. Swetha on personal. Yeah.
Thank you.
Yes, and because there are some more questions and the time is running out. So we'll take these last two questions. One is, would dyslexia also come under neurodivergent condition?
yes.
Yeah. And can online tests be trusted to determine ADHD or dyslexia when we know that the parent, had it and it's a possible cause, therefore is a possible cause?
So these are all just hints for you to, probably it gives you a probability, an index of suspicion, but
Okay.
a formal diagnosis with standardized tests need to be done.
Correct. And ASD is a disease declared by WHO. Is that correct? I mean, is that
So
ASD?
the whole revolution is moving to a rights-based approach. So actually, if you see the DSM-5, the classificatory systems, so they have moved the entire conditions under the neurodevelopmental disorders.
Okay.
It's under it's a developmental, it's a lifelong trajectory. So we don't actually use the word disease.
Disease, yeah, okay. It's
Disorder.
more developmental and it is, yeah, okay. So how to control video games or screen time playing on the phone for teen child with SLD?
Yeah, so behavior modification is very important. Having a structure is very important. So, parents need to be in charge over the situation. So when there is a proper reinforcement schedule, so your reinforcement in terms of it can be different types. Like, for example, normally you would do things and buy things for the child. Instead of that, if you are able to reinforce, like, for example, the child has these expected set of things which the child has to do through the day, and on completion of those tasks is where the child gets that specified time. You can, as a parent, you should determine how much amount of screen time. Like, for example, children less than 2 years, zero screen time. But for a teenage child, they would. So now we need to understand that as you progress on the family life cycle, so a teenage child needs to have some autonomy, so some space. But at the same time, there is an amount of supervision also needed. So you negotiate with the child and you say, this is the time for it, and it is contingent on completing these specific things. And if you're not able to do it, then you lose the privilege. So that has to be done consistently. Only when you do behavioral interventions in a consistent way, that is when behavioral interventions will work.
Thank you. That's very helpful. For an ADHD middle schooler who is very impulsive, is homeschooling a better option?
Okay. So now we need to understand that. I think so there are people who are divided on these opinions. But I will give it to you from a scientific perspective, right? Not so there are a lot of advantages for homeschooling, but in the context of an ADHD, right? So now you need to understand, for the overall development of a child, the stimulation is very important. Like, for example, an ADHD child can have social skill deficit, right? Now, unless you put the child in that environment and you teach the skill, it's a naturalistic environment. Now, as long as you keep the child within the four walls and you do not expose the child to that environment, then the child will not be able to learn the skill. So I think even if you, due to your personal convictions, you choose homeschooling, there should be still certain events, enough social opportunities should be given to the child, so that we need to work on the trait of impulsivity.
Yeah, I think this also has to be something personal, I guess. Okay.
Yes, actually, yes. The whole idea of asking is that the child is she's my daughter, and she's been going to formal school set up right since beginning. But with the entering the puberty age especially, it's flared up. ADHD has flared up, and practically no academics is happening at all from her side. It's wrong to say that she's not doing it. She's just not able to. She's not able to focus through. Her focusing capacity is just like a class 3 child, 4 child, with a huge amount of curriculum put on her shoulders. So, and also at the same time, very highly stimulated with all the stuffs happening in the school. Everything is like floating in her head. She's currently under medication. But I'm thinking like, is this the juncture where I should take some decision for her betterment? So what would be a medical perspective in this regard?
So for ADHD, the evidence, if you see, classroom modifications are very important. Like, for example, you need to now, so it should be done on case-to-case basis. So if you decide to keep her in school, so you need to come up with a clear plan from the therapist. What would be, so because teachers are also overwhelmed, as in they do not have the background training how to deal. So we kind of work with the teachers to give a individualized educational plan for these children. So what are the structural modifications? What are the behavioral expectations?
Yes,
So
ma'am.
if you have a school which can accommodate this and work through this, yes. But if the school is not supportive and you're not able to work on it, then maybe you will have to consider, homeschooling or, small groups, right? Yeah.
Okay. Okay, doctor.
So, any other questions? So I'll just tell you a small, this is not canvassing, but because, CMC Vellore, what the program we have, we are one of the pioneering institutes for managing neurodevelopmental disorders. And, so we are a part of, even the government and a lot of like the policy making. So key people from our department have been involved. So, what we offer, like what is different, why I'm saying CMC is, so we believe that parents have to be coached as co-therapists, right? So if you see the whole world, like the Indian scenario, the children who are coming to us, we see that healthcare has become more of an industry and parents are being exploited. So, going for, like, as I said, suggested a formal certification. So what we do is we have a 3 months parent mediated intervention. So where we coach the parent, how they can support. You're not really completely dependent on the therapist because you need that many hours of input to work with your child to achieve the desired potential. So if you need, like, so we have seen that research wise also, these parents who have undergone these training are much more competent, and they kind of say that this is the first time we are actually understanding this is the way to go about teaching a skill to the child. So if you have a difficulty in the city, or people come to us even from different parts of the world, from US, from Australia, so even from NIMHANS also they refer to CMC. So I strongly recommend that if you have the time, some of you have asked questions like you want to know on a personal basis. So if you're interested for a consultation, so as a CMC faculty, I can't take personal consultations. We do it only in the hospital context. So I'm just sending you across our unit email ID, childpsych@cmcvellore.ac.in.
Can you just put it on the chat box also, Swetha?
I put it. So you can send a mail to us with a reference to my name. You can put my name. So we will reply back to you. So even if you're not coming for the 3 months, if you are confused, if you feel that, you've been doing things, but, you're not reaching anywhere, right? So I would recommend that you take the time. So even people from Bangladesh and different parts come. So when we have the resource in our country, because I've heard like therapies have become so expensive. It's becoming a burden for the families also. And that is why we emphasize on parents being coached. Parents need to be trained so that you're independently be able to take care of your child. And we believe in empowering the mothers, especially the mothers, because mothers play a significant role in the development of the child. So I would recommend, if you logistic wise, it's an investment for the child. So I mean, it's a huge waiting list actually. So it's not that I'm campaigning for the institution. So please understand that, given that there is so much of mushrooming of therapy centers, and in that context, we need to provide to the to the parents what is the ideal. So there are very few centers who are going to give you that kind of a thing. Everywhere the therapists are providing therapy for the child, but the program is different in the sense that it is going to empower you as a parent. So your complete training on behavioral interventions, right? So that is something which the program focuses on. So if you would like to come visit the institution for further details, you can always send us an email and we will give you the further details. And so like for even one of our alumnus from CMC, there is Dr. Saili, who's a pediatric neurologist. She is in Kokila Ben, and I think a couple of hospitals. I'll pass on the details to Dr. Vinita. There are a couple of our specialists, people who have trained from CMC are in Mumbai. So you can at least go and, kind of understand what you're doing and, is there anything else to be done? And they'll be able to, serve as a connecting link to be able to discuss with us as a second opinion connect. Right? So, yeah, that's where I leave.
Very good. Yeah, you can just pass it on to me.
Yeah.
And if people want to get in touch, they can get in touch with us and I'll connect them with the concerned people.
Yes, yes.
Yeah. This is very helpful. I think it's great to have all of you all participate here today. And we want to just let you know that we will be continuing this conversation. This is just the first one. We're looking at having more people join subsequent calls and have some more sessions on this. But today I would just like to thank Dr. Swetha for making the time, being available for this after her schedule, her OPD schedule. She has come on this call. But we'll continue to have this conversation with different other team members also. Like she said, it's a multidisciplinarian. So we have a psychologist who can also help us. And we have a physiotherapist also who does work with autistic children. So we'd like to hear from everybody. Yeah, so since the time is up and overshot, I'd like to close it, but I'd like to thank each one of you all for joining from the different places. Yeah, you can just share your feedback on the feedback form. That'll be great for us too. And Dr. Swetha's email ID is also posted once again. I'm posting it once again. If you keep in touch with us, we'll be happy to help you all. So thanks a lot, Dr. Swetha.
Thank you so much. Thank you so much, ma'am. Both of.
Yes, thank you.
Thank you.
Thank you so much. Very helpful session.
Great. I'll be uploading this on the YouTube also, so you all can have a look at it later.